Good afternoon from Miami Beach, the offices of Neurosurgical TV. Today we have the pleasure of hosting another Association of Future African Neurosurgeons. Today we have Nathalie presenting initially, but first let's Nathalie Ghomsi. She's a general practitioner from Cameroon. But first let's meet the panelists. Okay, hello Marco, welcome.
Hello guys, my name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, northern part of Italy.
A frequent participant. And another Italian neurosurgeon, Maurizio. Hi Maurizio, could you please introduce yourself?
Yes, I'm Maurizio Iacovangeli. I'm a neurosurgeon in Ancona, Italy, Adriatic.
Okay, welcome.
Polytechnic University of Marche.
Okay, welcome, Maurizio.
Thanks.
Hello, Fortune. How you doing? Can you please introduce yourself? Let me unmute you here, Fortune. Okay, unmute. Sometimes I have a hard time unmuting someone. Oh, go ahead, Fortune.
Yes, I just want to join you on my computer because right now I'm on my smartphone, so it's not easy on smartphone.
Okay, what's your name and where you're from and what you're doing? A student?
Okay, I'm Fortuné Gankwe. I'm from Benin, but I live in Morocco. I'm a resident, neurosurgery resident at the Assantou University Hospital of Fez. It's in north of Morocco.
And a friend of Nauru. That's great. Welcome. Hello, Ulrich. How are you doing?
Hi, everyone. I'm Ulrich Sidney. I'm a research associate at a program in global surgery at Harvard Medical School, and I'm equally the founder and president of the Association of Future African Neurosurgeons. Nice to meet you all.
Very good. Welcome. Nagu, Emmanuel, could you please introduce yourself? Can you hear me okay? Perhaps not. Okay, Nathalie, welcome, and it's all yours.
Okay, thank you, John. Hello, everyone. Really nice meeting you and seeing you back again after a long time. I'm Nathalie Ghomsi. I'm a general practitioner in Cameroon. As we said earlier today, as John said earlier, I'll present today on the penetrating head trauma. Penetrating head trauma. I said earlier today, I'm going to present on penetrating head trauma. In order to, my presentation will follow this plan. After a brief introduction, I'll talk a little about its epidemiology. I'll try to outline the mechanism of injury so that we can better understand what penetrating head trauma is about. I'll also outline its physiopathology, the diagnosis, its management, prognostic, and then I will conclude. Penetrating head traumas are injuries that occur when penetrating traumas are injuries that occur when the object pierces the skin and enters the tissue of the body, creating an open wound. But then penetrating head traumas, also known as penetrating brain injuries, is when there's a breach of the coverings of the brain, that's the meningitis, with high chances of damage on the neurovascular tissues. All traumatic brain injuries which are not the results of blunt mechanism is classified as penetrating brain injury. Although less prevalent than blunt head trauma, PBI carries a worse prognostic. It remains one of the most devastating lethal forms of trauma. Its prognosis is generally poor, and for those who survive long enough to make it to the hospital, the management of PBI presents complex challenges to medical and surgical providers in the civilian sector. This image is showing this a child, a 17-year-old child. This is a study which was done by Dr. Kabulo under the supervision of Professor Kalangu. A 17-year-old child which demised after a penetrating head injury by a gunshot. It represents 14% of all head traumas for Carvalho and all in 2018, and this finding was similar to that of Singe and collaborators in 2017, which was 12% of all head traumas. approximately 70 to 90% of these victims die before arriving at the hospital. And 50% of those who survive to reach the hospital die during resuscitation attempts in the emergency department. Approximately 32 to 35,000 civilian deaths are attributed to penetrating brain injuries each year, with firearms-related injuries being the leading cause of mortality in this group. In the United States, for example, among approximately 20,000 gunshot injuries to the head, we have approximately 20,000 gunshot injuries to the head every year. Half of these gunshot injuries are due to suicides. These injuries have a higher mortality due to suicide, has a higher mortality due to the close ranges at which the firearm is discharged. In 2010, for example, the total healthcare costs attributed to traumatic brain injury were reported by the CDC as $17.5 billion, with severe traumatic brain injury accounting for 90% of the costs. Traumatic brain injury, in order to understand better the lesions that we cause, that we have during penetrating brain injuries, we first have to have a knowledge about the ballistics, and the different energy, the energy used to create the different lesions, which are different from that of blunt trauma during penetrating head injuries. It's a result of energy being, a traumatic brain injury is a result of energy being transferred from an object to the human skull or an underlying brain. The penetrating object has a kinetic energy that is proportional to the projectile, equal to the mass times the square of its velocity. Most non-bullet penetrating objects such as nails, knives, or scissors impart less damage to the skull and brain because they have less kinetic energy to transfer on impact. So on this radiography, on this X-ray, we have, it was an anecdote. It's a young guy, a gentleman who entered in the hospital in Mexico and who had a scissors, he was stabbed by a scissors into the head. He was called a gentleman of with penetrating brain trauma because the guy was very nice. He was very polite when he entered. He wasn't shouting. He wasn't crying because there was a scissors in the head. He was very polite and was very calm. On the second image is that 17-year-old boy. That's the second X-ray down. Is that 17-year-old boy that we saw previously by Dr. Professor Kalango and Dr. Kabulu, who had a penetrating injury of PBI. We can see a bullet inside at the center of the head. Ballistic is the study of dynamics of the projectiles, and ballistic properties depend on the kinetic energy, its mass, its velocity, the shape, and other properties such as the weight of the person who uses the gun or the projectile. Wound ballistics is the study of the projectile acts on the tissue. The bullets tend to have less mass but travels at higher velocities, though bullet velocities can vary based on a number of factors such as the muzzle velocity, traveling through the air, the travel to the impacted target. Modern firearms projectile velocities can range from 200 meters per second in handguns to more than 1,000 meters per second in some rifles. High velocity bullets fired from rifles have the potential to do more damage than bullets fired from handguns, though some large caliber handgun rounds are of sufficient mass to make up for their lower velocities with regard to kinetic energy. Other factors which can influence PBI include distance from which the round is fired, the yaw or tumbling that occurs when the bullet impacts the soft tissue. The bullet design causes it to deform or fragment on impact. Bullets fired from closer ranges often cause more damage than when the same bullet is fired from a longer distance. Example for those who commit suicide. Non-deforming projectiles have a tendency to yaw inside the tissue, which increases penetration and results in moderate wound cavity size, while deforming rounds have more superficial penetrations but forms larger wound cavities. On this graphic, it tries to represent the permanent and temporary wound cavities in ballistic gels. Permanent and temporary cavities in ballistic gels. This permanent cavitation is caused by the cavitation that we have on the trajectory of the projectile, while the temporary cavity, that's the image around, is the sonic waves that the projectile produces on its trajectory. There are different factors which determines the extent of injury. We have the low velocity projectiles, low kinetic energy, minimal shock waves, such as knives, that has a speed of less than 100 meters per second, and weak points of entry of the skull. As for high velocity projectiles, they have a high kinetic energy, high shock waves. Examples, we have the guns. We have the nature of the projectile, point of entry and the angle of projectile, the characteristic of the intervening tissues in the brain, in the skull, and the anatomic and neurovascular structures of on the passage. In 1988, Facker and Alltright came out with a classification for PBIs. They classified them into 5 categories. This classification helps assist providers in surgical planning, anticipating complications, and prognosis. The first type is the tangential wounds. Here, the projectile do not penetrate through the skull. The projectile impacts the head, as you can see here, and the head at an angle, and results in a superficial damage of the scalp without wounding the parenchyma. But though it is associated with the best prognostic, tangential injuries can cause underlying injuries to the skull, meninges, and cortex, including skull fractures. In meninges and cortex, we have skull fractures, CSF leaks, epidural and subdural hematomas, or cortical contusions. The second types are carrying injuries. Here, the projectile penetrates. It is a very unusual type of injury. Here, the projectile penetrates the skull, but travels along the periphery of the cortex without penetrating through the parenchyma. In this type of injury, we have a high risk of venous cyanosis injury, and therefore we can have subdural hematoma or intracranial hemorrhage. The third type, we have the penetrating injuries, where the projectile enters, when the projectile penetrates the skull and the brain parenchyma and then remains inside the brain parenchyma. The fourth is the perforating injury. In the perforating injuries, they are usually caused by high velocity projectiles. They are the most devastating. Here, the projectile penetrates the skull and then exits at the side distal to the entry point. It is both penetrating and perforating injuries are usually associated with other cerebral injuries such as cerebral contusions, hematomas, CSF leaks, pseudoaneurysms, and arteriovenous fistula. We shall see more later. The fifth is the ricochet injuries. In this type of injury, the projectile penetrates the skull and the brain and then ricochets on the inner table of the skull. This occurs often with low velocity projectiles and creates a new wound trapped in otherwise uninjured brain tissues. As we said before, here is an MRI which tries to illustrate the 5 categories of penetrating brain injury. We saw the perforating injuries where the projectile penetrates the brain and the parenchyma and then exits at the distal part of the opposite to the initial entry. We have the penetrating injuries where the projectile penetrates the skull and the parenchyma and then remains inside the parenchyma. We have the ricochet. We have the careening where it penetrates the skull and then travels at the peripheries of the parenchyma without touching the parenchyma, without injuring the parenchyma. And then we have the tangential injuries. As for its physiopathology, there's immediate intracranial injury as a result of neural and vascular destruction caused by the projectile traveling through intracranial tissues. Once the projectile strikes the head and transfers its kinetic energy to extra and intracranial tissues, destruction occurs in tissue both in the projectile parts, and as well as distant tissue outside the projectile part, creating the permanent and the temporary cavitation. Permanent cavitation occurs in tissue directly in the projectile part, but the sonic waves, as I said before, followed by the pressure waves of as much as 30 atmosphere produces a temporary cavitation that's around the projectile part. The expansion and retraction of the temporary cavities will cause distant punctate hemorrhage and neuronal membrane disruption. This results in rapid rise in intracranial pressure and intracranial pressure as the hematoma enlarges and cerebral edema increases as early as 30 minutes after the initial injury. That's why patients who present PBI at the beginning usually do not have a loss of consciousness. Some can present themselves with being normal and then they deteriorate secondarily. Currently, cerebral perfusion pressures decreases. Concurrently, cerebral perfusion pressure decreases and infarction can follow if severe herniation can occur. Kajaveli and collaborators described reduced regional cerebral oxygen and consumption and concurrent global glucose uptake in animal models. They referred it to as penetrating ballistic-like brain injury model. They noted that there's the lesion core and the perilesional areas showed lesion core and perilesional areas showed similar metabolic impairment, but with less severe metabolic impairment and less neurodegeneration occurring in the later. Coupled with the knowledge that mitochondrial damage in the cavitation zone results in the release of various neuroinflammatory mediators that can cause necrosis and neuronal apoptosis in distant tissues. This information provides evidence that perilesional lesions should be amenable to acute surgical and medical therapies and yet to be identified as neuroprotectant. This was best explained by Zolo 2 weeks ago. In contrast to blunt trauma, hemorrhagic shock and cardiac arrest can occur secondary to blood loss. The scarred risk of vascular supply and hemorrhage from meningeal vessels, parenchymal vessels, and venous sinuses can result in death by exsanguination. Acute traumatic coagulopathy due to release of tissue thromboplastin from the brain can result into diffuse intravascular coagulation, which this can be seen particularly in the setting of polytrauma, but also isolated head injuries. Early identification of related bleeding complication or emergent resuscitation is an important factor in decreasing the mortalities of patients with PBI. As we said earlier, the clinical diagnosis is usually a little bit poor. The patient can present itself with a heavy bleeding from the head, which can be from the scalp, or even which can be also from the scalp. It can present with a otorrhea, which can be taken for a basal skull fracture, which replaces respiratory distress, seizures, loss of bowel and bladder function, neurologic deficits or loss of consciousness or even coma. The utility of various neuroimaging methods used in patients with PBI lies on the potential management of prognosis implication of these modalities. Important findings include we have to know the entry, we have to know the entry and the exit sites of the projectiles. We have to know it helps see intracranial fragments, missile tract and its relationship to both vessels and air-containing skull-based structures, intracranial air, transventricular basal ganglia and brainstem injuries, missile tract crossing the midline, multilobar injury and basal system effacement, brain parenchymal herniation and associated mass effects. Neuroimaging is vital for surgical decisions. It helps the neurosurgeon to see the type of surgery that could be done, the size and the site of the craniotomy or the craniectomy, the route for extraction of the foreign body, as well as the decision to choose non-surgical management, which is also not uncommon in PBI, in the management of PBI. The first type of neuroimaging proposed is plain films. It identifies the cranial wounds, locates missile and bone fragments, and the presence of intracranial air. This exam is usually used in the low and middle income countries where you don't have the possibility of having CT scan. However, evaluating the projectile trajectory with plain radiographs alone can be misleading in the presence of intracranial ricocheting or fragmentation. Besides, the availability of CT scanning largely precludes the use of plain radiography, and it is not more routinely recommended, except in our low and middle income countries where we don't have a choice. The CT scan is a primary modality used in the neuroradiologic evaluation of PBI. It is quick and easier to do, and it provides improved identification in the driven bone and missile fragment. It characterizes the missile trajectory, evaluates the extent of brain injury, and detects intracranial hematoma and mass effects. All patients, it should be noted that all patients with craniocerebral gunshot injuries should be imaged emergently with an enhanced CT scan, regardless of whether or not there is an evidence of penetration on clinical examination. Postoperatively, CT scan can be helpful in evaluating the development of intracranial hematomas, the presence of residual foreign bodies, and the extent of cerebral edemas. As for the MRI, the magnetic resonance imaging is not generally recommended for the use of acute management of PBI. It is time-consuming and can potentially be dangerous when there are retained ferromagnetic objects because of the possible movement of the object in response to the magnetic torque. Though it can be used in PBI caused by wooden objects, that's if you are very sure that it's a wooden object. Cerebral angiography is used in patients who have PBI with a high risk of vascular injuries. This high risk could be seen during when doing the CT scan in this patient. It depends on the wound trajectory seen on the CT scan. For example, if the wound trajectory is through or near the Sylvian fissure, that's location of the M1, M2 segment of the middle cerebral artery, the supraclinic carotid artery, the vertebrobasilar vessels, the cavernous sinus, or the major jugal venous sinuses, a cerebral angiography should be asked. Peripheral branches of the middle cerebral artery, followed by the anterior cerebral artery, are more vulnerable to PBI lesions than in the internal carotid artery. The development of unexplained subarachnoid hemorrhage or delayed hematoma could suggest vascular injury. Here we have a pseudoaneurysm of the M4 branch, the M4 segment of the middle cerebral middle cerebral artery, which occurred after a gunshot. As for the monitoring of intracranial pressure, the concept is based on Morrow Kelly, as Dr. Sidney rightly gave us the explanation last time. The brain volume, it says that the brain volume, the brain volume may increase because of edema. That's predominantly cytotoxic after trauma. Vascular volume can also increase if venous outflow is blocked, or if there is an increased cerebral blood flow because of seizures, pyrexia, or loss of autoregulation. Cerebrospinal fluid volume may also increase because of blockage of outflow tracts, or hindrance with reabsorption. An increase in the ICP is documented to be a predictor of worse prognosis. The treatment measures are just as that of blunt trauma. That's the use of hyperventilation, the use of mannitol. You can do CFS drainage, lumbar drainage, the use of high-dose barbiturates, or more recently use decompressive craniectomy. Now let's talk about the management of PBI. The main aims of the management of PBIs are debridement and devitalized tissues, evacuation of hematomas, removal of accessible bone fragments, removal of bullet fragments, obtaining hemostasis, dural closure, and repair depressed skull fractures and decompression of edema hemispheres or edematous hemispheres. The first modality we can have is surgical management. Local wound care and closure can be used for injuries where there is a small entrance of bullet wounds and there's no devitalized tissue, with no significant intracranial pathologic findings. More extensive wounds with non-variable scabs, bone, or dura should be debrided more extensively before primary closure or grafting to secure a watertight wound. When there is a significant mass effect, necrotic brain tissue should be debrided and safely accessible bone fragments should be removed. Intracranial hematoma should be evacuated. Routine surgical removal of bone and missile fragment loads distant from the entry site, especially in the eloquent areas of the brain, is not recommended. It has been documented to correlate with worse outcomes and higher morbidity. A conservative approach towards cerebral debridement in general has thus been recommended. It should be performed within 12 hours of the injury to decrease the risk of infectious complications. When the trajectory of the missile violates an open air sinus, a watertight closure of the dura should be done, as the literature suggests that it may decrease the risk of abscess formation or CSF and CSF fistulas. It is debatable that which technique amongst craniotomy or craniectomy is the best to achieve the most optimal results. No statistically significant advantage of one technique over the other has been described in reports of morbidity or mortality rates associated with the two procedures. A recent large study of military patients suffering from severe PBI reported optimum outcomes with early decompressive craniectomy. Secondly, we shall talk about the management of vascular complications. Vascular complications account for 5 to 40%, 50% of all PBI in various reports. Wounds with higher risk of vascular complication include orbitofacial or derional PBI, the presence of intracranial hematoma, and injuries with fragments crossing 2 or more dural compartments. The common complication we can have is traumatic intracranial aneurysm, as we saw earlier, arteriovenous fistula, subarachnoid hematomas, and vasospasm. Traumatic intracranial aneurysms accounts for approximately 20% of traumatic traumatic brain injuries. Of 20%, 20% of traumatic aneurysms after a traumatic brain injury are caused by penetrating brain injuries. Traumatic intracranial aneurysms caused by PBI are mainly false aneurysms, that's pseudoaneurysms. Once identified, surgical and endovascular repair are the treatment options. On this image, we have on this angiogram, we have the image of a pseudoaneurysm of the anterior cerebral artery, of a branch of the anterior cerebral artery just here. As for subarachnoid hemorrhages, the frequency is of 31. Its frequency in PBI accounts for 31 to 78% of PBI. It has been documented to correlate significantly with a high mortality. Additionally, subarachnoid hemorrhage near large vascular territories and intraventricular hemorrhage may lead to poor outcomes. Here we have the penetrating. We have a penetrating category, a penetrating category of PBI, where we have we can see the subarachnoid hemorrhage by this hyperdensity of the basal systems. As for vasospasm, it is a dreaded complication of subarachnoid hemorrhage, which is caused by reactive smooth muscle contraction in the walls of the vasculature. It can lead to ischemia and infarction. It can be detected by increased velocity on Doppler sound. Its treatment include medical management or endovascular angioplasty. Its medical management includes the reduction of the blood pressure, hypervolemia, and hemodilution. Talking about CSF leak, it is a common complication of PBI, about 28% of PBI with high prediction of infectious complications. It develops because of the dural tear by the missile along with a failure to adequately seal the defect by normal tissue healing processes. The guideline for the management of penetrating brain injuries recommended the surgical correction of CSF leaks which do not close spontaneously or are refractory to CSF diversion through a ventricular or lumbar drain. The injury wounds associated with CSF leaks need to be extensively explored in order to allow watertight closure by the neurosurgeon, either by direct closure of the dural defect or by using grafting material. Though these synthetic grafting materials can, however, by virtue of being a foreign body, become a potential source of infection, and they must be used cautiously, especially in grossly contaminated wounds. There is a high risk of inhalation syndrome, so care should be taken before placing a lumbar drain. So this is an image which illustrates the placement of a lumbar drain. As for antibiotic prophylaxis, infectious complications are not uncommon in penetrating brain injuries. As for usually the object which is causing the injury is usually a foreign body. So coming with all the germs which can be found on the surface of the body or outside. And they are also associated with high morbidity and mortality rate. The risk of local wound infections, such as local wound infections, meningitis, ventriculitis, or cerebral abscess, are particularly high among PBI patients because of the presence of contaminated foreign bodies, skin, hair, and bone fragments driven into the brain tissue along the projectile tract. More frequent when cerebrospinal fluid leaks, air sinuses wounds, or transventricular injuries, or they are more frequent when the CSF leaks. They are more frequent when CSF leaks, air sinuses are wounded, or we have transventricular injuries, or those ones crossing the midline we have wounds which causes the midline. Staphylococcus aureus is the most frequently associated organisms. The administration of broad-spectrum antibiotic therapy is deemed necessary in this case. A study done by the British Society for Antimicrobial Therapy on infections and neurosurgery recommended the use of a triple antibiotic, double antibiotic for PBIs. We have the use of intravenous coamoxiclav, that's amoxicillin and clavulanic acid, 1 per 2 grams every 8 hours, or the use of intravenous cefuroxime, 1.5 grams, and then 750 milligrams every 8 hours, associated with intravenous metronidazole, 500 milligrams every 8 hours, or 1 gram every 12 hours per rectum, or 400 milligrams every 8 hours through the mouth. As for the use of prophylactic anti-seizure treatments, the risk of post-traumatic epilepsy after PBI is high, probably due to the direct traumatic injury to the cerebral cortex, with subsequent cerebral scarring. About 30 to 50% of patients suffering from PBI will develop seizures. It is estimated that up to 10% of them will appear early, that's the first days after the trauma, and 80% during the first 2 years, but 18% may not have their first seizures until 5 years or more years after the injury. It is recommended to administer prophylactic anticonvulsivants such as phenytoin, carbamazepine valproate, sodium valproate, or phenobarbital within the first weeks after the injury. The prognosis of PBI depends on various the prognosis of PBIs depends on various entities. We have its age. The more the patient is old, the lesser the prognosis is good. We have the suicide attempt, as we said before. In suicide attempt, the patient, the projectile is too near the skull. So usually patients which commit suicide have a less good prognostic than those being shot at distance. It depends on the mode of injury. As we said, low velocity projectiles are better than have a better prognostic than high velocity projectiles. A patient with PBI should maintain a good pressure, a good arterial pressure. As any patient presenting with hypotension, since this patient will present with usually uncontrolled bleeding or severe bleeding, this patient it should be regulated. This hypotension has to be regulated fast, so that the prognostic of the patient should be better. Patients with coagulopathy have a lower prognosis. With respiratory distress have a lower prognosis. The lower the Glasgow Coma scale, the more the prognosis is bad. Patients who have an increased intracranial pressure have a low prognostic. And if on the CT scan, we have findings such as bihemispheric lesions, multilobar injuries, intraventricular hemorrhage, ankle herniation, or subarachnoid hemorrhage, these patients usually have low prognosis. To conclude, we see that PBI is though less prevalent than blunt head traumas carries a worse prognostic. The publication of guidelines for the management of penetrating brain injuries in 2001 attempted to standardize the management of PBIs. Optimal management of PBIs requires adequate comprehension of the mechanism of injury and its physiopathology. CT scan remains the exam of choice of PBIs. CSF leaks are common in PBI patients, and surgical correction is recommended for those which do not close spontaneously or are refractory to CSF diversion through ventricular and lumbar drain. The risk of post-traumatic epilepsy after PBI is high, and therefore the use of prophylactic anticonvulsivant is recommended. Advanced age, suicide attempt, associated coagulopathy, Glasgow Coma Scale of 3 with bilateral fixed or dilated pupils, and high initial intracranial pressure have been correlated with worse outcomes in PBI patients. We shall not, these are our references, we shall not finish here. I'm going to present on a case study which was done by Dr. Kabulo under the supervision of Professor Kalango. As I said earlier, he was a 17-year-old boy, previously well, who was shot on his head by a friend when they were playing. The main complaint after the shot was mild headache. He had no seizures, no loss of consciousness, or any deficit of any kind. On clinical examination, the hemodynamic parameters of the child was good. That's with a BP of 110/69, pulse of 67 beats per minute, a respiratory frequency of 18 breaths per minute, a temperature of 36.1 degrees Celsius, and a SpO2 of 100% on free air, and a Glasgow Coma Scale of 15/15. His pupils were at 3 millimeters bilateral, that was normal, no deficit. Biological findings were without any peculiarity. When the patient, when the child was run an X-ray, we found this bullet, image of the bullet intracranially, so he had a penetrating category of head injury. On CT scan, we had the same image. As we can see, the cavitation is very important. The cavitation through which the bullet pass is very important. This is it. This was the trajectory, and we have lesions around. We have lesions around. So on CT scan, they confirmed the bullet placement in the supratentorial space with hemorrhagic contusion in the left cerebellar hemisphere and posterior fossa pneumocephalus. The sulci and gyri were effaced and no evidence of intraventricular hemorrhage. You can see here the ventricles are really free. There's no hemorrhage. The evolution was that the child remained fully conscious and neurologically intact for 24 hours. After these 24 hours, the level of consciousness suddenly started deteriorating, associated with vomiting. And when he was trying to be run to the CT scan for another brain scan, he demised on the way. So on postmortem, a postmortem examination was found the bullet inside was in accord with the CT scan. That's the bullet was at the supratentorial level. I thank all of you for your attention.
Thank you, Nathalie, for putting that all together. Pretty large presentation overview. We're fortunate enough to have 3 neurosurgeons here. Let's get their take on what you said and anything they want to say about closed head trauma. Do you want to make some remarks, Marco Milani? Are you there, Marco?
Yes, I am. No, just want to congratulate with Nathalie. It's a great presentation, very complete, that face topics not so common, because as she just told, most part of these patients don't reach the operating room, so it's unusual. That's it.
Okay, any remarks, Dr. Gabullo? Hello, Dr. Gabullo.
Hello, Dr. Bennett. Hello, everyone. Congratulations, Dr. Nathalie. That was a great presentation. Yeah, I came a little bit late. I found you on pathophysiology. So that was great. Congratulations. So like you see in the case you presented, they affect us like you mentioned before, they affect us which carry poor prognosis, like a bullet which is crossing the midline, a bullet which is crossing the posterior fossa, a bullet which is also crossing at the level of basal ganglia, and also a bullet which is crossing at the zona fatalis. Zona fatalis is just the zone which is a few centimeters above the cellar region. That's where the vessels forming the circle of Willis are. So that carries also a poor prognosis. Like our patient, there was a posterior fossa, because the bullet entered through the anterior ear, it went in the posterior fossa, then up, it crossed the tentorium, and it was found in the splenium of the corpus callosum. So we had all things, like 3 factors for poor prognosis. But that was a great presentation. Thank you so much.
Thank you, Dr. Cabullo. Maurizio, do you have much experience with penetrating head trauma? Go ahead. Oh, I'm sorry, Mauricio, let me unmute you there. Okay.
Yes.
Go ahead, Mauricio.
Yeah. First of all, a great presentation, very explicative, clear, fluent. Congratulations. Actually, here in Ancona, we do not have lots of penetrating brain injury.
Okay.
We have a lot of car accident, falls, but penetrating brain injury, not so much. In our experience, the difference between the PDI and the other kind of trauma is there is, unless the very severe case that unfortunately they died, there is not so an emergency in sending the patient in the hospital. Of course, as fast as possible, okay. But beside the car accident, most of the penetrating brain injury we have, especially from knife, they came in our OR, ER working themselves. So this is, I would say, the difference. The penetrating brain injury, unless the most severe one, give you much more time to be treated.
Okay, very good. Okay.
I have one more comment, Dr. Bennett.
Go ahead, Dr. Will.
Yes, I was also saying there are cases you can get an intracranial bullet and the patient survives for more years. In literature, there is a patient who survived with an intracranial bullet for 27 years, and the bullet was in the brain. And there is another one, it was like 30-something years, and it was now migrating, going down into the spinal cord, in the subarachnoid space. And it was now removed when it reached the thoracic region. So sometimes you can get patients like that, and they are surviving more years with the foreign body inside. If you check very well the literature, Nathalie, you will see that patient, the bullet migrated and it was removed around the thoracic region. It was a very interesting case. And another one, the patient survived with 27 years with an intracranial bullet, and he died from something else, not from the bullet. Yeah, thank you.
And some patient already didn't know to have a bullet, because sometimes the penetrating hole is so small that patient even do not recognize just a little bit of pain, but nothing. And then you make the diagnosis even years later. I have a case.
True.
So generally speaking,
seems incredible, but could happen.
So generally speaking, if the patient's stable medically and not deteriorating neurologically, there's no great hurry to do anything, correct?
Not for the most severe case, but the percentage of patients that have not a so quick secondary injury with respect to car accident is higher in the penetrating brain injury.
Mm-hmm. Okay, very good. Any students have any comments or questions? Abdullah.
John.
Hello, Abdullah.
Yeah, well, good evening, Mr. John. Thank you so much. I'm very impressed with the preparation and the details with which the presenter made the points very clear, especially the pathophysiology, very impressive. A point I want to make here is we should have a distinction between a free-flying object injury and impairment injury. The pathophysiology should differ. The mechanism of injury and the danger it causes to the brain differs. Now, the second thing I want to say is that the two things that must be put in mind while managing patients like this, antibiotics and anticonvulsants. These two things, I think, should be mandatory in managing this patient. That's the point I want to clearly make in this presentation. In summary, she has done wonderfully well.
You know, I'm surprised that the convulsion rate is so high after that. So it's not, it's a preemptory step. I mean, convulsions are going to happen, right? With anybody with a penetrating wound of the head, they're going to happen in most cases. Convulsions.
So yes, it will happen. That's why anticonvulsant, that is, in this instance, it is advised that somebody with penetrating either free-flying missile injury or impairment injury should have anticonvulsant in addition to antibiotics. It's mandatory.
Okay. Very good. Okay. Ulrich, do you have any comments or questions? You look like you're getting ready to say something.
No, I mean, we've had a great presentation and very, very detailed, and we had a lot of contributions from various neurosurgeons. Just taking the opportunity to thank everyone who's always coming. I mean, it means a lot for us to have you guys here and have all this expertise. We don't take this for granted. We know that it's not that often that you get the opportunity to have this many surgeons from all over the world commenting. So it helps a lot, and it helps everyone grow. This is not only an exercise of learning, but it's equally as a form of mentorship. So thank you so much for being around.
Yeah, I totally agree with that. And it will be available forever on YouTube, Nathalie. You'll be able to refer to this work forever. It'll be on celluloid. So we'll go on. Any more closing comments or questions? Or
Okay, Dr. Bennett.
Go ahead, Dr. Gabulo.
I just wanted to show this paper.
Okay, go ahead.
Can you see it?
Yes.
Yes, so it is called craniothoracic bullet migration over a period of 27 years.
Wow.
So this was a case report published in Mexico by Castillo. Like you can see, so it was now found in the thoracic spine after 27 years, wow. And it was removed. So yeah, wow. So I think I wanted just to show you that case.
Yeah, incredible experience. Wow. Okay, very good. So we'll go on to the next presentation. Let me just cut this
for the neurosurgeons. For this patient of 17 years with that bullet at that level in the brain, would we have saved that child? Would it be possible to could it have possible? Because there are some studies who says that if you even remove, sometimes when you remove even the bullet, it can have it can cause other lesions while you're removing the bullets, which will.
Thank you, Dr. Hello. It depends on where you are. Depend on where you are and the facilities you have. Like we are here in Africa, it will be difficult without neuronavigation, without stereostatic facilities, because if you go blindly with your forceps, you miss your bullet. It means you are damaging more brain than the bullet did. So, but if you have other facilities like stereostatic, whatever, you can still go and remove that bullet. So it depends on where you are. Okay.
Okay.
So can I come in here, please?
Go ahead.
While I'm trying to make it between in penetrating mesial injury and impairment is that in impairment, we all know that you have to leave the object there until you fully investigate before you know what to do in terms of the approach and how to remove it, because the impaled object might be tamponading a major blood vessel. We all know that. I failed to say that earlier on. Now, concerning the patient she presented earlier that eventually died, the patient presented initially, the clinical condition was very good. She said the patient was very okay. And I guess where facilities are available, the patient should be reviewed and monitored repeatedly, especially when the condition started deteriorating. Two things likely happened. It's either the patient continuously was bleeding and the hematoma was enough to cause significant raise intracranial pressure, and the patient decompensated and of course died, or massive edema that followed. Whichever of the two, if the patient was monitored well, if it was hematoma, it could have been, the patient could have been rescued. If it was edema, the patient could have had decompression, just like you said in your presentation. That's my view, actually.
Very good.
If this patient had a monitoring, if you could have, I guess it's in an LMIC that it happened. But if you could have a monitor of ICP, for example, do you think the prognosis of this child would have changed? Do you think
yes. ICP and neuroimaging. Imaging is very important so that you know exactly, specifically what is causing the problem. ICP is increasing, but if it is a hematoma, you can't detect that just basically on ICP. You need image to know what is really causing the ICP. Is it just edema or some bleeding somewhere? My own take here is that the patient presenting earlier in a good condition something ought to have been done if facilities were available and the patient was monitored well. Apart from ICP monitoring, imaging follow-up as well could have led you to really what was going on, and you could have done something. Decompression could have, if it was just, of course, I think it was that caused the problem, in addition to probably hemorrhage.
Okay, very good. Let's wrap this up and move on to the next presentation. Thanks everyone for coming, especially the neurosurgeons. And Nathalie, thank you very much.